Hi friends, I am Dr. B.B. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the prolapse of rectum, partial and complete, and also anal incontinence. Partial prolapse. The mucous membrane and submucosa of the rectum protrude outside of the anus for less than 1.5 inches. When the prolapsed mucosa is palpated between the thumb and the finger, it is evident that it is composed of no more than a double layer of mucous membrane. This occurs usually in extremes of life, in small children and in elderly people. In infants, due to the undeveloped sacral curve predisposes to the condition or direct downward course of the rectum. The presence of a rectal adenomatous polyp must be excluded. In children, the partial prolapse usually occurs after an attack of diarrhea or after severe whooping cough or from loss of weight and consequent diminution in the amount of fat in the ischiorectal fossa. In adults, the condition is usually associated with third degree of hemorrhoids. In females, torn peritoneum predisposes to prolapse. In males, straining from urethral obstruction may predispose to it. In old age, both partial and complete prolapse are due to atony of the sphincter mechanism. Partial prolapse may follow an operation for fistula in ano, where a large portion of muscle has been divided. Here the prolapse is usually localized to the damaged quadrant and is rarely progressive. Prolapsed mucous membrane is pink and prolapsed internal hemorrhoids are plum colored and pedunculated. Treatment. In infants and young children, digital reposition. The mother is taught to replace the protrusion. The distal 2/3 of the index finger is wrapped with Kleenex tissue. The finger is inserted into the protrusion and the mass is eased into the place. Gently the finger is withdrawn, leaving the Kleenex tissue to disintegrate. In some of malnutrition, dietetic adjustments are necessary. Submucous injection. If a digital reposition fails after 6 weeks trial, injections of 5% phenol in almond oil are carried out under general anesthesia. Technique. At the apex of the prolapse, the submucosa is injected circularly so as to form a raised ring. Up to 10 ml of the solution is injected. A similar injection is made at the base of the prolapse. Alternatively, if the prolapse can't be brought down, the injections are given through a proctoscope. As a result of aseptic inflammation following injections, the mucous membrane becomes tethered to the muscle cord. Diet operation. If the prolapse persists in spite of above measures, the said operation will definitely succeed. In infants, insertion of the little finger into the anus before the wire is tied is recommended. In adults, submucous injection of phenol in almond is occasionally successful. Excision of the prolapsed mucosa. If the prolapse is unilateral, the redundant mucosa can be excised after inserting and tying the good cells ligature, which after the needle have been cut off permits the base of the prolapsed mucous membrane to be ligated and three portions lying in juxtaposition. When necessary, the operation is combined with the hemorrhoidectomy, and if the pedicle of one or more of the hemorrhoids is broad, Goodsell's ligature is applied. Complete prolapse or procedentia. It is less frequent than the partial type. The protrusion consists of all layers of the rectal wall. It is usually 4 to 6 inches long. On palpation between the finger and the thumb, the prolapse feels thick and consists of a double thickness of the entire wall of the rectum. Any prolapse more than 2 inches length consists anteriorly between its layers a pouch of peritoneum so a complete prolapse is a sliding hernia occurring through the pelvic diaphragm. When large, the peritoneal pouch contains a small intestine which returns to the general peritoneal cavity with characteristic gurgle when the prolapse is reduced. The prolapsed mucous membrane is arranged in a series of circular folds. Complete prolapse is not common in children. In adults, it can occur at any age. Women are more affected than men and is usually associated with the prolapsed uterus. The obese patients are more affected. In children, when abdominal pain, ileocecal intussusception protruding from the anus and the rectosigmoid intussusception in adults, there is a deep groove between the emerging protruding mass and the margin of the aneurysm, hence can be differentiated. Treatment. The thrust operation is recommended in elderly patients, the patients who are suffering from injury or disease of the spinal cord, and in feeble-minded in whom the condition is relatively common, as well as in very early life. Thrust operation. A short incision is made in the midline anteriorly and posteriorly about half an inch from the anal wedge. Large bore hollow needles are inserted at a time through the posterior wound in such a way as to encircle the anus half inch from the orifice till their position emerge from the anterior wound. A malleable silver wire gauze 19 or 20 is introduced through the points of the needles. The needles are withdrawn. The assistant introduces his index finger into the anal canal and the surgeon tightens the wire around the finger by twisting the ends of the wire. The finger is withdrawn and the ends are clipped short and bent back. The wounds are then closed. A glycerol suppository or a low pressure enema is given as required post-operatively. Confinement to bed is not necessary. In about half of the cases, the wire may break. However, it can be easily removed and the operation is carried out several times at intervals on the same patient. The disadvantage is spurious incontinence of feces caused by fecal impaction may occur in all age groups. On stubation, there is foreguarded against vigilantly. Operative suspension of the prolapsed bowel. The following operations are simple and are recommended in patients with complete prolapse who are otherwise healthy. Lahart's operation, incision. Left lateral median incision is made and the abdomen is opened. A circular incision is made around the rectum through the peritoneum covering the pelvic floor. The prolapsed rectum is liberated and drawn into the peritoneal cavity. A cup of pelvic peritoneum is attached to the rectum as low as possible. The second step of operation consists of extraperitonealization of the redundant portion of the rectum and the distal portion of the sigmoid colon. This is accomplished by dissecting the medial and lateral leaves of the anterior parietal peritoneum from the abdominal wall, ligating and dividing the inferior epigastric vessels during procedure. The peritoneal coat now is free from the anterior abdominal wall. Its cut edges are sutured behind the rectum and the sigmoid. The anterior rectus sheath and the skin are then closed in front of the redundant bowel. Adhesions soon develop between the exteriorized gut, the peritoneum and the abdominal muscles. The long-term results of this operation are good. Wells operation. Here the rectum is fixed firmly to the sacrum by inserting a sheet of polyvinyl alcohol sponge between them. The rectum is separated from the sacrum. The sponge is fixed by a series of sutures to the periosteum over the midline of the sacrum and is then wrapped loosely above the rectum, covering all except the anterior wall. The free margins of the polyvinyl sponge are sutured to the lateral margins of the anterior wall of the rectum. The peritoneal floor is resutured so that the sponge lies excluded from the peritoneal cavity. The polyvinyl sponge won't give rise to foreign body reaction, but it produces marked fibrous tissue formation. Many proctologists regard this method as the method of choice. Now we will discuss about anal incontinence. It is of many types. Congenital incontinence. In case of imperforate anus, partial or complete lack of sphincter mechanism is the exception. Patulous anus associated mental deficiency. Traumatic incontinence. The most frequent cause is the complication of a complete perineal tear during parturition. Other injuries are rare. Post-operative incontinence. After the anorectal ring has been severed during an operation for a high fistula in ano, conservative perineal resection of the rectum for carcinoma. Associated with advanced complete prolapse due to atony of the sphincter. Interruption of the reflux are responsible for sphincter control in disease of venous system, nervous system, notably neurosyphilis or TAPS dorsalis. Carcinoma of the anus involving the sphincter. The treatment. The treatment comprises of partial incontinence is often can be remedied by the Fred's operation. This is also the operation of choice in case of complete incontinence associated with mental deficiency. Partial and complete incontinence due to parturition is particularly amenable to operative treatment. Posterior perineopathy with repair of the torn edges of the sphincter often cures the condition. The song about the prolapse of the rectum and in the prolapse of the rectum, partial and complete, and anal incontinence. And in the next video, I'll discuss about some other disease. Thank you.